the outset, thanks to Dr. Fazili for including me in his course. And as we discussed, that IFIS is of course become a menace now, especially as the life expectancy is increasing. So, but there are strategies and there are devices available now which makes our life very easy in the cases which we get IFIS. So I'll just quickly share a few videos with you to make my point clear. First, let's see what is our protocol nowadays. This is the case. This patient was, so firstly, it's very important that we take a history from patient. There are 4-5 things questionnaire which are stamped there on any paper of the patient, and one very important is, are you taking any medications for prostate or for urinary retention or like that. So that makes point clear, and so those patients who are not dilating and are on those, so straight away these patients like this. So this is a case which had a black cataract and the pupil which is moderately dilated. See, if this patient doesn't have any history of using tamsulosin, we won't use any dilated device here because this pupil is almost 5.5 millimeter dilated. But I know that this patient is on tamsulosin, has moderately dilated pupil, so straight away we use Maligan ring in these cases, which makes our life very easy. And moreover, this is a black cataract, so straight away we go and put Maligan ring. So once you put this device, we all know it lies in the pupillary plane. But the beauty is that it maintains the whatever dilatation is there. It doesn't let the pupil come down on you during the surgery. So once you put this and look at the hardness of the cataract, it's total black cataract. So I use drill and chop technique. Pupil is very well maintained, and you finish off surgery, put IOL, enlarge the axis to appropriate size. This is another beauty of this device, that you can actually size your capsular axis well and take off this device. And see, once I take off this device, pupil again comes down, and once I start doing irrigation aspiration of the residual OVD, the iris starts coming in the side. So had I not used this device in the beginning, believe me, look at the billowiness of the iris when I'm putting this, hydro-stitching the incisions. So this is the standard protocol now. Patient is on tamsulosin, moderately dilated pupil, or so straight away we go ahead and use this pupillary dilator device rather than struggling during the case. So I'll show 2-3 videos here. Now have a look at this. As we were discussing, that the intraoperative maneuvers are very important. So this is the case. Patient was not on tamsulosin, but many cases they also have floppy iris because of many other reasons, other drugs which they have been using. We really don't know what all drugs they are using. But thing which I want to show here is, look at this. Now again iris starts coming out. So at this point, so what you don't have to do is, you don't have to go and straight away push OVD here, because there is a lot of fluid which is trapped inside. So I go ahead and burp the incision, put pressure on the posterior lip of the incision so that the excess fluid comes out. And once you have the excess fluid coming out, then you go ahead and put some OVD there. The same thing from the side port, go ahead and put little OVD. So you need to be very slow, and I just hydrate the wall of the incision so that we have tight incision there, incisions are not leaky. Then I go ahead and finish this case. So this is just a mild floppiness of the iris which doesn't cause much of the intraoperative problem, but you need to be careful with your maneuvers, that they are very gentle. Another case, as Dr. Snowball said, that rhexis, till this time I'm making rhexis, pupil is well dilated, sorry. And the moment I do hydrodissection, pupil starts coming down. And this is a softer cataract. I make a trench here. And again, there is mild floppiness of the iris, as you can note here. It starts coming towards the side port. So if there is just mild floppiness, you don't have to come out again and again and try to push the iris. Just let it be there. It's a mild floppiness, little bit of iris tissue is there, but you can safely complete your phaco. And then just go ahead and put some OVD. Pupil comes down, but so always do bimanual IA in these cases because the main port is bigger. If you try to go through main port, the iris will tend to prolapse. So just go through side ports, do bimanual IA and exchange hands. Try not to touch the undersurface of the iris. Once you touch that, pupil will become smaller. So this way you finish the case. Take off OVD. So this is the mild floppiness of the iris, which you can easily manage if you are very gentle in your maneuver. And hydro stitch all the incisions. So last case, another case was on tamsulosin, and the pupil is again non-dilating. So as I said, our protocol is straight away go ahead and put the Maligan ring here. So I go ahead and put Maligan ring. So once you put this ring, you get perfect dilatation of the pupil. You can safely take out the nucleus. And look at the billowing of the iris, which keeps happening. So here it scores over any other ring, Maligan ring, that it's sturdy. It maintains the pupillary dilatation very well. And go ahead and put OVD, enlarge the axis to desired size, and be careful while taking out all the scrolls from the pupillary margin. And once you take it out, have a look at the propensity of the iris to come toward the incision. I'm just showing that. So I think with the pupillary expander devices or iris hooks or any other device which you are comfortable with, if you do use these devices right from beginning, it makes your life very easy and case very simple and safer for you. Thank you very much.
Harshul,
Yes.
how many times are you, by your expertise and your ego, stopped from using pupil expanding device right there this time?
No, see the thing is, what I believe is that if patient is on tamsulosin, I don't have to struggle in between, no. Because once you put this device, it makes surgery very simple, and patient understand that. Why not to use a device which is so simple, which is safer, which gives better result rather than struggling with the iris tissue. You have atrophic patches here and there, you know. So that's my thinking is.
So the carry-home message would be
To use any expanded device. My preferred device is this, but if patient has history of tamsulosin, patient is not dilating, you have to use expanded device, or you have to dilate the pupil.